All right, gang. So not a uplifting topic at all, but we are talking about caring for patients with a life-threatening illness and need to discuss some of the ethical issues related to the end of life. Okay, so this section sometimes brings up things that students are not quite ready for, but it's very necessary to look at ourselves and our own sort of fears and views about death as we're considering coming into contact with patients who may very well be reaching the end of their own life. Okay, so let me ask you a few questions. What would you consider to be a natural lifespan? What would you consider to be a premature death? What about a tolerable death or an acceptable death? Page 91 of your text goes into some thoughts that people have about maybe what makes it an okay time to go. Have you fulfilled all your life's duties? Can I leave this earth now without still having duties to my children, to my spouse? Will my death create profound grief for those left around me? You know, these are all things people are wrestling with. Have their life potentials been met? Okay. Some common fears of death. What fears do you have about it? And again, how will you respond to that in yourself so that you know how to respond to those fears in others? Some common ones, fears of death, are pain, disability, suffering, lingering in this unwell state, this painful state, loss of self-control, loss of autonomy. How do you imagine your death to go? You know, again, maybe you don't want to think about it, but how old do you think you'll be, right? Are you prepared to go? What do you consider the best possible way to go? So lots of different things to grapple with. You know, what happens when somebody goes before it's the, quote unquote their time, before their duties are discharged, and it's not unacceptable. Maybe they're too young. Okay, so as we're caring for terminally ill patients, we need to remember that patients need as much information as we can give them. Of course, we're going to consider the needs of their culture. And as you're reading through Spirit Catches You, you're seeing some of those cultural needs play in. Okay, we're going to always be listening carefully to their fears. We will provide the best treatment possible. We will give emotional support. We want to be aware of their goals and help them accomplish their goals as possible. Remind the patient that you still care even if therapy comes to an end, okay? We want to be sensitive to the timeline that they're living with. Maybe they've been given a year to live. Maybe they've been given less, okay? That might change some of their fears. That might change their feelings, depending their timeline, okay? We're also showing interest in the patient, but not encouraging a relationship that fosters dependence or interferes with their family relationships, okay? We'll consider giving referrals to palliative care, making them comfortable at the end of life, or hospice care, okay? So some ethical principles that come into play here are autonomy. Would you think differently about these principles in a patient who is dying, right? So we are going to respect a person's autonomy. We are thinking about non-maleficence, which is do no harm, or to minimize harm in attempting to do good for this patient, make them comfortable. Beneficence is doing good in terms of the patient's values and what they consider to be important to them during this time of terminal illness. And justice, we are acting fairly and justly always. Now we'll talk about some concepts here when we're formulating a caring response to a terminally ill patient. And we'll talk about abiding versus abandonment. Your text goes into these a bit. Ordinary versus extraordinary care. And we also want to talk about medical futility. So in your text on page 91, I just want to read you a paragraph here. This is under the heading of the health professionals' response. Health professionals sometimes find it comfortable to avoid emotional engagement with death, even though and partly because they deal with it more often than most people. To some extent, this emotional reserve functions as an aspect of professional distance that enables therapists to cope in difficult roles without burnout. Yet, over-detachment is not the only or best alternative in caring for patients. So, we're human, right? We are going to care for our patients. We need to find out the best line to walk as far as maintaining professional distance, but yet not being overly detached, okay? So abiding means being present with the patient or the family, being honest with your own self about feelings that you have around the end of life, and I'll say also being honest with the patient as it's appropriate to their feelings about the end of life, okay? And being focused on the patient as the recipient of care. Now, abandonment is the opposite pretty much. That means withdrawing from the patient, either physically or psychologically, and withdrawing care prematurely. Your text, bottom of page 90, right after that paragraph that I just read on page 91, talks about how, why do physicians in particular all too often abandon patients once death becomes certain? I think that's something to think through. They're becoming detached, but what do you think about that? Is it appropriate? Again, we need to find that line of not turning away from patients, but also instead providing appropriate care, interacting with them, even given their anxieties about dying, and not withdrawing from them prematurely. Now, ordinary versus extraordinary care. So ordinary care is like typical, what's commonly used in care appropriate to the diagnosis, okay? Extraordinary care means going above and beyond, like even to the extent of heroic measures, all that could possibly be done. The bottom line is the patient is the one who decides what's ordinary or extraordinary care. Page 92 and 93 of your text give some really good example, I think, of a patient who got to work with two different therapists during her illness, and she talks about how she preferred the one who, in her eyes, gave her extraordinary care, went above and beyond. Page 92, 93, kind of look through that. There's some really good suggestions that come out of that discussion. Page 93 about recommendations for an appropriately caring response from the eyes of the patient, okay? Now, medical futility, when does it become appropriate to discontinue caring for a terminally ill patient? Patient can refuse therapy. Page 93 of your text and talks, going into page 94 now, highlights this. When is it appropriate to continue therapy? When is it appropriate for the patient to refuse therapy? You could think of it as kind of quantitative versus qualitative. Quantitative means that it will be decided there's no reasonable hope of success in terms of the usual goals of medicine. Okay, this is based on the experience of the healthcare team. All right, versus qualitative, there's no reasonable hope of achieving the goals of the patient. That's determined by the patient or somebody who's qualified to make decisions on their behalf. Okay, so either one talks about the issue of when is it appropriate to discontinue care, okay? Either qualitative or quantitative. So as we are considering, the end of life, we want to think about how, we talked about spirituality a couple weeks ago. maybe that was last week. Sorry, I don't remember. You know, as people are coming to the end of life, we might find for the first time even some people's focus are now shifting from the traditional kind of Western medicine biomedical model to now a more psychological, social, or spiritual realm. Okay, they are thinking about, okay, again, grappling with tough questions. Who am I now that I'm sick or dying? What's the meaning of my life when I'm no longer productive and independent? And these thoughts might be playing into their reasoning. Okay, it's medically futile to consider to continue with my treatment, right? They're thinking about what their relationship is to the supreme being, to God, to the ultimate being, to the universe, whatever, however they think of that, okay? They're thinking about what they value most in the time that's left to me. Maybe they want to be comfortable. Maybe they don't want to continue on with cancer treatments, okay? They're more able to focus beyond fear and into what choices they have when their symptoms are managed and when pain control is appropriately provided. Okay, so as people are making decisions at the end of life, we'll talk about advanced directives, palliative care, and hospice care. Okay, now a person, what do I mean when I say, are they competent to make decisions? Okay, so competent patients engage in a 3-stage process prior to any challenge to their capacity to make health decisions. They think about what their values are and what their preferences are. They communicate these to their loved ones and healthcare providers that are involved in their care, and then they document these values and preferences, hopefully in an advanced directive document, okay? I put an example of an advanced directive in the module for you to look at. So, whether or not a patient is competent to make decisions, this process can be initiated by the patient themselves or by their immediate family. It also can be initiated by a physician or other healthcare provider. Okay, so setting up an advanced directive, if you will, can be initiated by the patient, by their family, by a physician or another healthcare provider. Okay. So some things to think about in regards to advanced directives. I put a few laws up there for you if you ever want to reference those as you're looking over the material that's in the module, okay? And then palliative care, okay? Palliative care means is care that specializes in the relief of the pain, the symptoms, and the stress of a serious illness. The goal of palliative care is to improve the quality of life for patients and their families. So who benefits? The patient does, and their families benefit too. Palliative care is appropriate at any point in a serious illness. It can be provided at the same time as a treatment that is meant to cure the illness. So it can be provided at the same time as, say, like chemotherapy, okay? Again, palliative care is care that specializes in the relief of the pain, the symptoms, and the stress of a serious illness, and the goal being improving the quality of life for patients and for their families, so both the patients and families benefit. Now, hospice care is multidisciplinary care that approaches the physical, the medical, the emotional, the social, and the spiritual needs of the dying patient and their family members. Hospice care is directed at pain and symptom management to enhance the quality of life and enhance interaction with family and loved ones. And also hospice care does provide bereavement support after the person passes away, provides some bereavement support to the family. Okay, so there's some similarities, yes, between palliative care and hospice care. Some concerns when we're talking about end-of-life care. Does the person have adequate pain control? That is the number one fear of dying, is that it's going to be painful, okay? Patients tend to underreport their pain at the end of life, and they do still have the fear of becoming addicted to drugs, okay? Doctors fear over-medicating patients. There's this idea of a double effect, which we'll talk about. Nurses may decrease the doses due to being provided just too much pain medication. Sometimes nursing staff may actually decrease doses as appropriate. So we'll talk too about patients being very depressed at the end of life, very, I think, common, and some challenges of just managing their symptoms, right? So many patients initiate discussions on assisted suicide because of poor pain and symptom management, because of not wanting to be a burden to their loved ones, not wanting to be dependent on people, and because of the cost of the overall cost of the care. So the principle of double effect, page 97 in your text goes through this. Now, here's just an example. So increasing morphine to alleviate pain, even though the increase could be the cause of death shortly because the respiratory system might fail because of the morphine increase, okay? So the principle of double effects does hold true that the action, say that the doctor is giving more pain medication, okay? The action itself must be morally indifferent or morally good. The motive must be the achievement of the good effect, okay? So the physician giving a patient more morphine to help alleviate pain the motive is to alleviate pain, the good effect, right? The bad effect, the respiratory system may fail. The bad effect must not be a means to the good effect, and the good effect must be at least equivalent in importance or outweigh the bad effect, okay? So in the case of a terminally ill patient, you could say that giving them morphine to alleviate their pain, even though it may cause their respiratory system to fail, the good outweighs the bad in that case because they are terminally ill anyway, all right? Now, again, the patient having been competent to decide they wanted the morphine, I would say that's good. Family can decide. Physician may decide also, okay? The Death with Dignity Act allows terminally ill adults that are seeking to end their life to request lethal doses of medication from medical and osteopathic physicians, okay? These terminally ill patients must be Washington residents who have less than 6 months to live. So there you go. And there's the RCW if you want to look that up. All right, gang, that is it.